discoveries. Perfect. Perfect slide too, right on the presentation outline. So I'll talk about some of the progress we've made in antibiotic discoveries, and then finally, some of the challenges based on our research in Pittsburgh and things that we're doing across the PRECEDENT network with new and emerging mechanisms of resistance, and what might be some things that keep us in this field awake at night. So many of you will recognize this slide. If you've written grants, you've cited it as a first line in your grant proposal. If you've given presentations on antibiotic resistance, you've probably used these figures. This, of course, is a very now well-cited report from Sir Jim O'Neill out of the United Kingdom that was commissioned by the UK government to try to estimate what is the burden of antimicrobial resistance. Now, much like those initial CDC reports that I mentioned, there wasn't a lot of data to go off of on this point. So these were mostly projections, but probably most infamously, he projected by the year 2050, we'd see more than 10 million deaths annually due to antimicrobial resistance if we continue to be on this trajectory that we were on when he published this report in 2016. Notably, of course, that's more than cancer and a number of other chronic conditions that you see listed here. But it wasn't until this report was published in Lancet Infectious Diseases in 2022 where we really started to put some numbers around this threat that we often refer to. This is a report that was put together that really culminated all of the available evidence that was available up to the year 2019. And they made accurate predictions on what was the burden of antimicrobial resistance in 2019. And they did that by pulling together an astonishing 471 million individual patient records, 88 bug drug combinations, over 204 countries where data existed. So this was truly a monumental effort just to pull these data together. And what they did then with counterfactual statistical predictions is they estimated what is the attributable and associated number of deaths due to antimicrobial resistance each year. And you can see that those ranges are 1.27 to 4.95 million deaths every year. So certainly this is a global problem of public health significance. And as we pointed out previously by the CDC, those same bugs that we worry about, CRE, MDR, Pseudomonas, ESBLs, were the bugs that were driving mortality in this report. So fast forward now, we're up to 2019 and the CDC has published an updated report. This is the version 2.0 of antibiotic resistant threats. And still here you see a number of infections, almost 3 million, and a higher number of deaths, almost 36,000. But really the reason those numbers went up is we had better data available to us. And with better data, you can make more accurate predictions. But this report in 2019, for many of us in the field, was really saw and perceived as good news. Because what this report showed in the details is the number of deaths due to antimicrobial resistance was being reduced, an 18% reduction from where they were in 2013. So this was great news, and the epidemiology of many of these resistant organisms was on the decline. So perhaps in 2019, we thought we were starting to turn a corner in terms of treating resistant organisms. Of course, a few things changed after that, most prominently COVID-19. And then this report later was published in 2022, which unfortunately showed the reversal of much of that progress we have made in antimicrobial resistance because of COVID. And you guys all know you were on the front lines of what happened. We reallocated surveillance resources. We overused antibiotics. Infection control was completely rewired. And as a result of that, and a downstream consequence of that, we saw the number of resistant organisms being identified in hospitals go up exponentially. You can see the percentages in the red font here, but carbapenem-resistant Acinetobacter, Enterobacteriales all increased significantly, as well as antifungal threats like Candida auris and antifungal resistant Candida. So this is a major problem that we're now facing and still being challenged with in the day-to-day practice. So often we wonder then, well, how long does a major disturbance like this last and persist when you're talking about the epidemiology of resistant organisms? Well, the CDC has published another report in July of last year, July of 2024, which says the rates are still up. They appear to have plateaued in 2021. That might hopefully be the peak of what we see in terms of resistant organisms in this country. But you can see if you just compare 2021 to 2022, that rates aren't going down. They really are stable, and in the case of Candida auris, still going up, which means we're still above where we were in 2019 pre-pandemic years. So we certainly still have a number of challenges in front of us because of these kinds of numbers. I was talking with some of you earlier today about how we track antimicrobial resistance at my hospital. And we've been tracking carbapenem-resistant pathogens since 2000 in my hospital, and you can see here data from that. These are unique patients with carbapenem-resistant organisms tracked year after year. And what I want you to appreciate from this slide is a couple of very important points. If you follow the colors carefully here, I'm going to show you first one of our major waves was this orange color, which was carbapenem-resistant Acinetobacter, which peaked at my institution around the time I was finishing residency in 2008 and 2009, but through good infection control practices was dissipated. At the time that carbapenem-resistant Acinetobacter were going away, we saw major rises in carbapenem-resistant Klebsiella, which again, we saw a wave and has subsequently dissipated, and it now has been largely replaced by carbapenem-resistant Enterobacter. But all of these waves of resistance really pale into comparison in what you see in the back forefront of this slide, and that's carbapenem-resistant Pseudomonas. So as soon as we think we have our finger on the epidemiology of resistant organisms, even data at one center show how quickly those things can shift, and we've seen certainly significant waves of resistance over time. But the totality of those waves is what's illustrated here. Counter to the data I just showed you for the CDC, our rates of resistant organisms have gone down almost every single year, starting from before the pandemic and through the pandemic, which hopefully is a testament to practicing good infection control and good stewardship is a very important and effective way of mitigating any outbreaks or subsequent transmission of resistant organisms in your institution. And so this is a slide I like to show to all of our hospital administrators, particularly when we're asking for stewardship support and additional personnel, and say, look, we're down all the way across the board with resistant organisms. And this is largely true. And we've had a number of concerted efforts and initiatives to get to this point. But I want to use this slide as a pivot point to start to outline some of the other things we've learned about managing resistant organisms at my institution. And I'm going to start with CRE, which you can see have decreased 43% over the last 8 years or so. And CRE, when you're talking about carbapenem-resistant Enterobacteriales, it's really important and critical to this story. If you start with what is the history of CRE in this country, and it really centers around one single enzyme. That enzyme is Klebsiella pneumoniae carbapenemase, which you all know as KPC now. But I would argue to you that that single enzyme drove drug discovery for more than a decade. Not only a number of new initiatives, but our ability to inhibit this enzyme from hydrolyzing beta-lactam antibiotics was the driver and key force behind a lot of the new drugs that we now use in our day-to-day practice. So just to remind you, KPC was first identified in North Carolina in 1996 in a surveillance culture. It was subsequently reported in 2001 in this paper in AAC, which I'm showing you. And as the investigators lay out in this paper, this is the first time they'd ever seen a Klebsiella that was resistant to imipenem and meropenem. They'd never come across one of these previously. And they found that, of course, there was a serine beta-lactamase known as now subsequently named KPC that was the cause of that. Since then, there's been a number of initiatives to discover the molecular epidemiology of KPC. And unlike some of the other organisms we'll talk about, really what made KPC successful is the transmission of a single clone. We now refer to it as sequence type 258 or ST258. But that single clone eventually became disseminated worldwide and caused outbreaks in every continent in our globe. So it's different than other organisms that share genetic elements. It is one single clone that expanded through clonal expansion. But by 2009, other things were beginning to happen. We were starting to see KPC in more and more hospitals, and probably now one of the more well-cited KPC outbreaks was at the NIH hospital, published here by Evan Snitkin, where he showed that there was a number of transmission events in the NIH hospital, leading, unfortunately, to a number of fatalities among patients at that hospital. And that spurred a whole series of news and media coverage around hospital superbugs. Many of you may remember some of these coverages. Here I've just taken a screenshot from CNN, where often what the popular media was telling the public is there's dangerous superbugs in our hospitals and they're untreatable. And to some extent, that, of course, was true. These were organisms that we really didn't have effective antibiotics for, but really helped to raise awareness around this field of antibiotic resistance. So going back to 2013, this first CDC report that I mentioned, let me underscore to you how dire these circumstances were. Because if you look at the epidemiology of CRE in 2013, as you can see in the middle of this screen, rates of CRE were increasing on every continent. They were going up exponentially, and our treatment options, as you recall, were exceedingly limited. We were using aminoglycosides, colistin. We got really creative and decided we would use 2 carbapenems at the same time to try to sacrifice one. The hindsight's really important here, right? It underscores how desperate we were to effectively treat patients with this resistant organism. And the general approach then was to use combinations of inferior drugs together because it's all we had. And we had to accept the adverse events and collateral damage that came with using those antibiotics. And for all intents and purposes, we had no pharmacokinetic studies to inform how we should even be dosing these antibiotics. Not surprisingly, then, if you look at observational reports around the same time frame, you'll find mortality rates of 30 to 50%. 1 in 3 to 1 in 2 patients infected with invasive infections due to this organism were dying because of our inappropriate treatment options. So we started thinking about these things at my institution. This is one of the first presentations that Neil Clancy and I gave at UPMC. This is a bench to bedside grand rounds that we do. And I put a number of old pictures on the slide here just to make fun of my colleagues mostly because they haven't aged a minute since, I'm sure. But this was in February of 2016. And that date's really important. And let me show you why. So in February of 2016, what we were doing is we were trying to keep up with the literature. We were trying to keep up with our clinical experience. And we're trying to find the best treatment option for KPC producing Klebsiella specifically. And you can see on the graph, what we had tried is a handful of salvage options like colistin and tigecycline. Then we started standardizing our approach for KPC, where we're using colistin and carbapenems together. And eventually we got to a point where through some laboratory studies, we found that porin mutations were really limiting the success of that particular antibiotic combination, where we started using aminoglycosides almost exclusively. And you can see our success rates improved over time, which is a good testament to translational research. If you can understand the underlying mechanisms of resistance, you can design even not so good antibiotics to overcome them. But it was true, we were using colistin, and I tell people we did it because it's literally all we had, as you can see in the susceptibility profile listed below. Well, what a difference a few years make, because later that year, ceftazidime-avibactam was approved by our hospital formulary. Now, avibactam, you guys know, is a diazo-bicyclooctane beta-lactamase inhibitor, and it's first of its class, in that it is the first beta-lactamase inhibitor to inhibit KPC, that single enzyme that drove drug discovery. Now we're starting to see some of the fruits of that labor. Now, KPC is well inhibited by avibactam, and the combination of ceftazidime-avibactam has then since broadly been used. Now, I'll talk a little bit about the pharmacokinetics of ceftaz-AV subsequently, because I know this is a very savvy PK/PD group. But importantly, I'll underscore that only about 30% of both ceftazidime and avibactam reach the epithelial lining fluid. That'll become important in a minute. But I also want to tell you and inform you that ceftazidime-avibactam, I assure you, will be the last antibiotic that ever undergoes 7 phase 3 randomized clinical trials. The drug development pipeline was not made to approve new antibiotics. And this drug not only had to go through a number of clinical trials to get approved, but also to get indications for infections that we now use. But what's even more startling about those 7 phase 3 randomized clinical trials is they enrolled almost no patients with CRE infections. And for all intents and purposes, like clinical trials, there weren't sick patients or immunocompromised patients in these trials. So what we've subsequently learned with using ceftazidime-avibactam has come almost exclusively through observational real-world studies, because of course we now use it in patients with resistant organisms who are sick. So this is the conundrum we were stuck with in 2016. We now have a new antibiotic with no clinical trials evidence, no real-world evidence at this point. It appears that it's safe and it's potent in vitro, but it's also the first time we've had a $1,000 a day antibiotic. So this perplexes stewardship programs, right? What is your return on investment then for $1,000 a day for a new antibiotic? Is that much better than using aminoglycosides and trying to preserve somebody's kidneys? Well, we kind of jumped in with both feet forward and said, we're going to standardize our approach to CRE, and we're going to use ceftazidime-avibactam first line. And what you do as a good clinician and translational researcher, when you don't have data, you start to generate data. And this is one of the first studies that we did. It included 109 patients that had carbapenem-resistant Klebsiella bacteremia. And you can see in the table, we divided those patients into 4 cohorts that align with that progression I showed you on a previous slide. We compared patients that got ceftaz-AV to patients who got a carbapenem plus an aminoglycoside, those who got a carbapenem plus colistin, or other combinations. And if you read carefully, you'll see that across these 4 cohorts, the underlying diseases of patients were very similar. They were similarly severely ill. We see about 30% of immunocompromised patients in these studies, ranging from 38 to 54% of transplant patients, which are common in my hospital. And they were all due to KPC. So really, outside of a clinical trial, we had some comparable groups. Albeit there's some confounders here, we felt pretty confident that we could compare outcomes across these 4 cohorts. And what did we find? When we define clinical success as surviving 30 days and improving signs and symptoms, you can see that patients who received ceftazidime-avibactam did significantly better. Rates of clinical cure were 85% compared to less than 50% for everything else. We also found mortality benefits in 90 days and 30-day mortality rates of patients who received ceftazidime-avibactam. And in multivariable analyses where we controlled for those confounders, we found that treatment with ceftaz-avi was an independent predictor of success. So maybe this was predictable in hindsight, but these were the first data we had that showed this is better than those older salvage agents that we had been using. And this, of course, was the first of now several studies that we rely on to tell us that use of ceftazidime-avibactam for CRE undeniably saves the lives of patients. I'm showing you a number of observational studies that have been published in a number of different countries, and they all show the same thing to me: significant reductions in mortality. And these are not small numbers. You're seeing major reductions of 20 to 30% across these studies. But there are some limitations, of course. The only data we have up into this point are largely centered around KPC-producing Klebsiella. And for most of those patients in the green bars that got comparative antibiotics, it was mostly colistin-based antibiotics, which we probably all agree now is an inferior treatment option. So what might be the new challenges then? If we've decreased mortality and improved patient outcomes, where do we go from there? Well, remember when I asked you to remember that date in February of 2016 when we said ceftaz-avi is now the greatest thing and we're going to use it for everybody? Well, unfortunately, I was back on the stage a few months later saying, hold on, there may be an issue here. And this was our Houston, we have a problem kind of moment, because shortly after employing ceftazidime-avibactam broadly among our patients, we identified 3 patients within the matter of a couple of weeks. And the same thing happened in all 3 of those patients. They've been treated with relatively short courses of ceftazidime-avibactam, and their baseline MICs, as you see from the green bars here, were significantly elevated upon recurrent infections. Their MICs drove way up for ceftaz-avi. I remember we were using e-test strips in my lab, and we'd never seen an organism resistant to ceftaz-avi in all of our surveillance work. So this is really a problem. And so we found then subsequently across the first 77 patients we treated, about 8% of patients developed resistance, prompting this narrative from Brad Spellberg and Robert Bonomo saying, maybe we're going to need a bigger boat. Of course, a reference to the famous movie Jaws. But we learned some very important things as a result of unfortunately finding resistance to this antibiotic. One of the first and most unique things we found is that when the organism developed resistance to ceftazidime-avibactam, there was a collateral sensitivity or increased susceptibility to meropenem at the same time. So if you look at these 2 pictures side by side, you'll see at the baseline isolate on the left, an organism that had a meropenem MIC of around 4 or 8, which we classify as resistant, and very susceptible to ceftaz-avi. This particular patient got 14 days of ceftazidime-avibactam for a bacteremia that recurred. And what happened on that recurrent post-exposure, the isolate obviously was resistant to ceftaz-avi, but very surprisingly to us, meropenem susceptible. Now, this is not only a problem clinically, but certainly a problem for your microbiology laboratories, which when they see a meropenem susceptible Klebsiella, they call that an ESBL. They don't call that a CRE, even though this organism is producing KPC. So we went further to try to understand what's the driving mechanism with this KPC mutation. And what we found is specific point mutations in what we refer to as the omega loop. And the omega loop is just part of the KPC enzyme that's really, really important for controlling substrate specificity. It essentially dictates which types of beta-lactam antibiotics this particular enzyme is going to hydrolyze. And one of the crystal structures is shown here, but we found mutations at aspartic acid 179, which really drove resistance. And essentially what happened is it made this enzyme a super hydrolyzer of ceftazidime. It essentially traps ceftazidime in the active site, hydrolyzes it, and limits the ability of avibactam to bind to the enzyme at all. And that was the cause of resistance. That's important, of course, when we start to think about, well, what might be the countermeasures to this kind of resistance? But clinically speaking, we had to also dig further. What were the clinical factors that were driving resistance? And here we saw that pneumonia and renal replacement therapy were very common among patients who were not only failing therapy with ceftaz-avi, but the same patients that were developing resistance. And for many of you, you'll know, well, pneumonia and renal replacement therapy are two places where I think about drug exposures. Am I achieving the right drug exposures in the setting of CRRT, depending on the flow rate? Am I getting enough drug into the lungs to effectively treat pneumonia? Remember I said ceftaz-AV gets into the lungs about 30%. So let me just ask a broad question of, well, are we using the right dose of ceftaz-AV, and were we all along? So we've learned a lot from the literature since this drug has come to the market. I'll tell you some of the preclinical work. If you dig deep, and you can find NXL 104 with ceftaroline, you'll find a great paper by Arnold Louis and George Rossano. It's a hollow fiber infection model, but what they show in that paper is that you need roughly about 8 milligrams per liter of avibactam to suppress resistance. So keep that in mind. You need 8 milligrams per liter to suppress resistance. Well, unfortunately, we don't even get peak levels of avibactam in the lungs above 5. Okay, so we're already below the threshold needed to suppress resistance in the lungs. But also what you'll find in the preclinical literature is that ceftaz-AV is remarkably safe. You can get a lot of avibactam before you see any toxicity. And this drug we know now was dosed conservatively, dosed really to inhibit ESBLs, not necessarily to inhibit KPCs. But there's no reason we couldn't get higher doses if we wanted to. There's no safety boundary that we're going to be stuck by. We know a lot more about the PK/PD targets for avibactam, but unfortunately, we don't know a lot about those targets in Klebsiella because they've all been studied in Pseudomonas and a murine thigh model. And we have no dosing recommendations to this day, more than a decade after this drug has been approved, for how to dose it in renal replacement therapy. Isn't that interesting? Well, what about the clinical outcomes then? Might there be signals that the dose might be wrong in clinical outcome studies? This is a very large study done out of Italy. It included 577 patients, all with KPC-producing Klebsiella infections. 391 of those patients had bloodstream infections. A lot of those sources of bloodstream infection were pneumonia, and they had about 80 patients with pneumonia specifically. Now, not surprisingly, when you look at the predictors of why patients died after treatment with ceftaz-AV, you see things you would expect to see: septic shock, neutropenia. We know those patients are at higher risk for death. But look at the other two factors that they found. Pneumonia and renal replacement therapy were independent predictors of death among patients with KPC-producing Klebsiella infections treated with ceftaz-AV. But you know what else they found? That if they gave ceftaz-AV as a prolonged infusion over at least 3 hours, and some patients even received continuous infusions, it was protective against mortality. That's a pretty strong signal that the standard out-of-the-box dose of ceftaz-AV might not be the right dose for patients with invasive infections due to this organism. And if you look at their Kaplan-Meier graph, you can see these lines separate fairly early, and they stay separated amongst a very large cohort of patients. So I would say to you, if you're using ceftaz-avibactam clinically, I'd be prolonging the infusion in every scenario I could, and perhaps even giving a continuous infusion. There's other signals that we've learned over the literature that when we're over-aggressive with dose reductions in the setting of renal impairment, it also predisposes patients to suboptimal exposures. Dr. K is nodding his head in the front here because he remembers in the clinical development for ceftaz-AV in an intra-abdominal trial, they were too proactive in adjusting doses, and those patients had higher rates of failure because they had acute kidney injuries that resolved in 48 hours. There's other data from Italy that shows when you adjust doses of ceftaz-AV, it leads to higher rates of death. And there's even more recent evidence emerging that you should be giving a loading dose of ceftaz-avibactam followed by continuous infusion. So these are all lessons that we've learned after having used this drug for more than a decade, but I think inform how we move forward. The other thing I want to talk about today is moving forward in the treatment of KPC and whether ceftaz-AV should be our first-line treatment option. Because, of course, a few years later, meropenem-avibactam was approved. And let me just contrast some of the differences between these two antibiotics for you from my perspective. I know you're very familiar with them, but I see meropenem-avibactam as a very potent in vitro agent. The median MICs are 0.06 and roughly around 1 for ceftaz-AV. Clinically and in the laboratory, we see much less selection of resistance. Not only is the frequency of resistance much lower with meropenem-avibactam, but the mechanism is important. Because the way the organism develops resistance to meropenem-avibactam is by altering its outer membrane permeability through porin mutations. Turns out porins are really important for acquiring nutrients in the environment as well. So they generally have a fitness and virulence cost to the organism that makes it very biologically plausible for the organism not to mutate in that way. I also want to go back to this pneumonia point. We worried about the exposures of ceftaz-avi in the lungs. Meropenem and vaborbactam in their healthy volunteer studies show excellent penetration in the ELF, almost a similar ratio of the two components. And of course, the Tango 2 trial was one of the first clinical trials that showed us patients did better in a randomized clinical trial with meropenem vaborbactam compared to a best available therapy in this particular trial. So let me go a bit further and underscore why I think real-world data is so important to what we do. These are the first 77 patients I mentioned earlier, 8 of which developed resistance, and that's how we got to our resistance rate of 10%. We quantified clinical success and survival in these patients, which again was much better than colistin and aminoglycosides, but these were the numbers for the first 77 patients. We published a subsequent study of the first 20 patients we treated with meropenem vaborbactam. So caution here, these are small numbers. But what we saw anecdotally are listed here. Same definitions, very similar patient populations, numerically higher rates of success and survival, less resistance, similar microfailure. Nothing statistically significant. I wouldn't make any changes based on these data. We're like, okay, maybe it's working. It's at least not worse than ceftaz-avi. But what happened since then is Atrium Health in North Carolina and Florida published their study comparing the two antibiotics, similarly small numbers, but almost identical trends in terms of numeric responses measured by clinical success and survival. And then Italy published their experience, showed almost the same trend. Now, unfortunately, in infectious diseases, we don't get phase 3 randomized clinical trials to answer the questions we want to ask. We have to rely on imperfect data. And I assure you, these are imperfect data. There's a number of confounders here in terms of time bias and rapid diagnostics and lots of things that could mediate this kind of response. But we also have to use the information we have to make good clinical decisions. And so at my institution, we've used this kind of information to say we prefer meropenem vaborbactam, not only from what we're seeing in observational studies, but based on in vitro potency and PK/PD parameters. And as a general rule, I believe that PK/PD is an important driver of patient outcomes. But of course, we need more definitive studies, and we are doing one such study in our PRECEDENT network. We call this the CAMEL study. You'll get a theme here in a few slides about our desert theme with camel and cactus, but we had to disband that theme. There's not that many things in the desert you can name studies after, as it turns out. But the goal here is to compare ceftaz-avi and merovabor for pneumonia and bloodstream infections due to KPC. Importantly, we're only including pneumonia and bacteremia because, of course, for urinary tract infections, you may not see a difference because the drug exposures are so high. Intra-abdominal infections, you may not see a difference because you need surgery and source control for intra-abdominal infections, not necessarily antibiotics. So what we're going to do is enroll patients across 40 hospitals in the US to get to 500 patients. We're going to control for any differences by inverse probability of treatment weighting after propensity score matching. But what's really important with some of the stuff we're doing in this PRECEDENT network is we've powered these studies based on a hypothesis. And so we've powered this study based on the hypothesis that meropenem vaborbactam is going to be better. And we'll have statistical power to show at least a 12% difference in clinical efficacy, but also we'll have the power to show at least a 9% difference in mortality and a 6% difference in resistance, all based on that observational study I've showed you. So we're optimistic on this and currently enrolling, and perhaps Rutgers can certainly be a site to contribute cases to this. So more to come on CAMEL, but hopefully this adds additional clarity of what should be the preferred treatment for KPC-producing enterobacteriaceae. Okay, all that to say then, well, we've come a long way since 2019, right? Or since 2013, right? Because if you look at now where we are with the updated CDC guidance, we generally don't use the salvage agents anymore. We have a number of new antibiotics that have been developed and developed with resistant organisms in mind. So we can generally use monotherapy, avoid adverse events, and not surprisingly, mortality rates are significantly reduced. So this is the good news around CRE. But unfortunately, in the field of resistance, every time you start to feel comfortable with good news and making progress, things like this happen. And so this is the black swan phenomenon that has been referred to for several centuries. Essentially something that wasn't anticipated, but has catastrophic implications. And then hindsight's always 20/20 said, yeah, we could have seen that coming. Well, I think the black swan event happening in the United States is NDM. And I think that because not only are we seeing an emergence of NDM on case-by-case basis, but we're seeing it in a number of unique ways. So NDM stands, of course, for New-Delhi metallo-beta-lactamases. It differs from KPC because it doesn't have a serine in the active site. It has 2 zinc ions that you see listed here. And importantly, it's not inhibited by avibactam or vaborbactam. and it's now spread globally, much like KPC has as well. But what makes NDM particularly challenging in that it is not one clone that's expanded across the globe. It is a plasmid that's been transmitted to a number of different Enterobacteriales species. Even as you can see on the screen here in the slide I'll show you, we find NDM in all kinds of weird organisms, which makes treatment and designing appropriate antibiotics a bit more challenging. Just briefly, this is an outbreak we had at my hospital. You can see just by the colors here, these are all the organisms in which we found NDM-containing plasmids. Not only did we identify patient-to-patient transmission, but we identified plasmid-to-plasmid transmission amongst patients' bacterial isolates. And overall, we identified 15 patients over 2 years. But what has happened at my hospital, as you can see in this chart, is that we never used to see NDM, going as far back as, say, 2019. But now, in the year 2024, we see about 50% NDM and 50% KPC. So it's clearly an emerging problem. And of course, we have much fewer antibiotics to counteract it. Okay, I'm going to change gears for the next 15 minutes or so and talk about MDR Pseudomonas. And I'll give you a moment to catch your breath because I know I'm putting a lot of information on you today. But I kind of consider Pseudomonas to typically be the elephant in the room. Because what we just talked about with CRE, those caught a lot of media attention, right? CNN was saying there's hospital superbugs in your hospital and nobody's safe. We've been managing MDR Pseudomonas for decades. This is an organism that resides in our intensive care units. It resides in chronically ventilated patients, cystic fibrosis patients. This has always been a threat. And if you remember that epidemiology at UPMC, just by number of patients, this is a far greater threat than CRE or Acinetobacter. So Pseudomonas to me is the paradigm of antibiotic resistance. Why do I say that? Well, the organism, of course, we know has a number of intrinsic mechanisms and defenses against antibiotics. Its outer membrane is very much less permeable than E. coli, as an example, making it harder to get antibiotics through the outer membrane. It has intrinsic beta-lactamases, most notably an AMP-C beta-lactamase we call Pseudomonas-derived cephalosporinase, or PDC, that can be overexpressed. It constitutively expresses efflux pumps. And what I mean by constitutive expression is it always makes efflux pumps. And it's a main reason why drugs like macrolides and tetracyclines aren't good anti-pseudomonal drugs, because they get efflux out of the cell before they have any inhibitory activity. And so the main efflux pump we'll talk about today is MEX-ABO-PRM, which stands for 3 different genes put together that make basically the substrate recognition, the tube that pumps the drug out, and then the outer membrane. And then finally, we know that Pseudomonas is unique because it has an incredibly large genome. But not only does it have a large genome compared to Enterobacteriales or even Acinetobacter, but a significant proportion of that genome is entirely dedicated to regulatory events, and that it has genes that encode regulatory events in response to stress, which would include antibiotics and, of course, environmental stresses as well. So when I talk about Pseudomonas, this is what I tell all the residents and fellows. Right? Maybe you recognize this movie and get the reference. But the first rule of antibiotic resistance in Pseudomonas is essentially there are no rules. We just saw a single enzyme knock out an entire class of antibiotics with beta-lactams and KPC. You can't make those same assumptions with Pseudomonas. And let me just show you briefly, without getting into too much detail, many of those mechanisms we talked about, AMP-C overexpression, efflux overexpression, changing the porins with OPRD, those all exist. But they all exist in various ratios and various combinations, meaning that you could see an organism that's resistant to cefepime, but susceptible to ceftazidime. Every time that happens, somebody calls me and says, this can't be right. They reported ceftazidime susceptible, and I know it's not. I said, no, it's susceptible. You can use ceftazidime. Because cefepime is unique in that it's a substrate for different efflux pumps in Pseudomonas that ceftazidime is not. There's usually a mechanistic explanation for weird phenotypes you see in Pseudomonas. Then you can see by the graph here that different drugs are affected in different ways. For example, meropenem is not hydrolyzed at all by AMP-C, where imipenem is. We know porin mutations have a very specific effect on carbapenems, but not other beta-lactams. So there's a lot going on with Pseudomonas, and that's really all I want you to remember from this slide. So let me talk about a common case that we deal with in our hospital. It's somebody like this, right? Somebody that's a chronic respiratory failure patient with a tracheostomy. They have a number of underlying comorbid conditions you can see listed there. And they're coming in and you pull up their prior micro and you see this. And you're like, oh, that's not good. So what we're seeing here is an MDR Pseudomonas susceptible to both ceftaz-avi and ceftoltezo. There's also a serratia along for the ride. And you're thinking to yourself, what am I going to start empirically here? Should I empirically be starting one of the new agents and maybe not have it if I need it? Should I start ceftazidime alone? These are very common questions with Pseudomonas. So let me break down how I kind of think of these drugs just very briefly for you. Ceftazidime, avibactam, and ceftolozane, tazobactam have been compared since these drugs were both approved 1 year apart. People have confused them for each other for several iterations of interns and residents throughout the years. These are very different drugs. It is true that ceftazidime, as you see on the right, is basically what composes ceftolozane. Ceftolozane is ceftazidime with a different R2 side chain, which I have circled in red here. But that R2 side chain does something very, very important in Pseudomonas, and that it increases the stability against many mechanisms of resistance. Not only does it make it more stable against AMC, it makes it less likely to be effluxed out of the cell, and it increases binding affinity for penicillin binding proteins. Why is that important? Well, I just told you Pseudomonas has multiple mechanisms of resistance. So overcoming just one mechanism of resistance in Pseudomonas generally is a short-term intervention, not a long-term solution. So when you add then beta-lactamase inhibitors to these compounds, tazobactam, I assure you, doesn't help you for Pseudomonas, unfortunately. I wish it did, but this is really there for Enterobacteriales. On the other hand, when you add avibactam to ceftazidime, we know we can inhibit AMP-C, but if you think about what causes ceftazidime resistance in Pseudomonas, it's both AMP-C and efflux. So we've overcome one key mechanism, but not two. I point that out because we see this in vitro data. Ceftolozane tazobactam is more potent than ceftazidime avibactam because we're overcoming multiple mechanisms of resistance. You see the MIC50 here is 1 versus 4. So generally speaking, there's about a 4-fold difference in MICs between these two antibiotics. That will become very important in a second. Before I get there, I want to underscore something that is a bit of a pet peeve of mine, and that people presume that carbapenem resistance is the same no matter which carbapenem you're talking about. It's absolutely not true in Pseudomonas. What causes meropenem resistance in Pseudomonas is loss of the outer membrane porins, OPRD, and increased efflux. Meropenem is a substrate for MEX-AB-OPRM. It gets pumped out of the cell. Imipenem, on the other hand, is not a substrate for efflux. For years, people have been trying to figure out why is imipenem not effluxed out of the cell, and they can't find a single pump that recognizes imipenem to pump it out. So it's very stable against efflux. Unfortunately, imipenem is a phenomenal inducer of AMP-C. Not only does it induce AMP-C, but it gets hydrolyzed by AMP-C, and similarly is affected by porins. Why is that important? Well, a drug we just talked about, meropenem vaporbactam. If meropenem's not being hydrolyzed by a beta-lactamase, adding a beta-lactamase inhibitor offers no value. And you can see in MIC data, there is no change in the MIC between meropenem and meropenem vaporbactam for this reason. So you assuredly should not be using meropenem vaporbactam for Pseudomonas. Okay, I don't have to convince you of that. But what about relebactam? Well, relebactam, again, inhibits AMP-C very, very well. It's a close cousin to avibactam as a diazobicyclooctane beta-lactamase inhibitor. And you can see a significant reduction in the imipenem MICs when you add relebactam. Okay. So what does this mean for you clinically? You still got to pick one of these drugs to treat your patient with, right? So which of the three that we consider to be potent anti-pseudomonal drugs are you going to pick? Well, sometimes we have to rely on surveillance data. These are contemporary surveillance data from the US, and you can see the rates of susceptibility to each of these three agents. I'll point your attention to the bottom. These are the hardest to treat, difficult to treat Pseudomonas, difficult to treat resistance, and you see a higher proportion of susceptibility to ceftoltazo. So many of us have changed our clinical practice to preferentially use ceftoltazo, as you should. And there's a number of reasons to say, well, perhaps is it better than ceftaz-AV? And I won't belabor your point with all the bullets on this slide, but the bottom bullet point is really important. We consider to at least be as good as ceftaz-AV until ceftoltazo wasn't available. Many of you recall in December 2020, Zerbaxa was removed from the US market and removed from the global market due to a manufacturing contamination. So this really pushed the envelope forward. What is the next best alternative for MDR Pseudomonas if you don't have the one drug that we've come to rely upon? And so I always say, well, don't let a good drug shortage go to waste. We can probably learn something from this. And that was one of the driving forces behind the Cactus study, which you've heard Dr. K mention. This was a study where we enrolled patients across 28 centers in the United States. And we did something pretty interesting. And Dr. Pogue, Jason Pogue, deserves the credit for this, in that when we were brainstorming this study, we said, maybe we should match patients, but let's match them within the study site. Because as you guys could appreciate, the way that these two antibiotics are used within individual hospitals is quite different based on formulary preferences, maybe local epidemiology, even clinician preferences. So we matched patients within the hospital themselves, one-to-one, ceftoltezo to ceftaz-AV, and we also match patients by things we know mediate outcomes: time to antibiotic therapy, severity of infection, and the infection site itself. So we met our targeted enrollment of 420 patients to test our hypothesis that ceftoltezo would be better. This was just published in December of last year and should be coming out in the formal publication soon. But what I'd like you to appreciate from our table 1 is how incredibly well balanced these two cohorts were. The matching worked. Dr. Pogue was right. Matching was the right way to get rid of residual confounders in these patients. You see almost identical proportions of patients in the ICU, on the vent, on vasopressors. Time to study drug initiation was almost identical. Outside of doing a randomized controlled trial, it's really, really hard to get observational cohorts to look this similar. And that's what we were fortunate enough to have. But not only that, these were really sick patients. We're still talking about 80% of patients in the ICU and 70% on a vent. So this is representative then of the real world patients that we struggle to take care of on a day in and day out basis. But what did we find? Well, we found that indeed, measured by our definition of clinical success, that occurred in a higher proportion of patients that received ceftolozane tazobactam, 61% compared to 52% you can see here. And when we controlled for the other factors you see listed at the bottom, our adjusted odds ratio was 2.07, suggesting higher rates of clinical success with ceftoltezo compared to ceftaz-AV. Notably, however, we saw no difference in mortality whatsoever. But our signal with clinical success was pretty strong across all of the subgroups. And one of the key reasons why we designed this study and around our hypothesis, we hypothesized that specifically the PK/PD of ceftoltezo was superior in the lungs. And so we thought if this drug was really better, the population we'd want to see a signal in is patients with pneumonia specifically. And at the very top, you can see the stratification by infection type, pneumonia or bacteremia. You see indeed even a stronger signal for pneumonia, suggesting that drug exposure in the lungs specifically might be a key driver for why we saw what we saw. This was consistent across ventilated patients, where we saw even higher rates of response if they were ventilated, septic shock, so on and so forth. But the other thing that we found in the Cactus study that was honestly a bit of a surprise is what I have circled in red here. More than 1 in 5 patients that got either antibiotic developed resistance. Well, that's not good. So 22% in the ceftoltezo arm and 23% in the ceftaz-AV arm. And again, these were resistance measured by imperfect measures. We only had retrospective data based on whatever microlabs were doing during the study period. So it's likely even an underestimate of the true rates of resistance. So this suggests that we still have work to do in the field of MDR Pseudomonas. And so let me tell you about just briefly a couple of cases that I think inform our strategy moving forward. This is an LVAD patient that we took care of at our hospital. Like a lot of LVAD patients, she had recurrent bloodstream infections, eventually culminating in a 2-week course of ceftoltezo treatment. This was actually the first patient that I was involved with that developed ceftoltezo resistance. And we got the susceptibility profile you see listed there. And this raised a whole number of questions for us. Why is ceftaz-AV also resistant? We never used ceftaz-AV for this patient. What happened with piperacillin tazobactam? If you follow closely, the pip-tazo MICs actually decrease from greater than 64 to now being susceptible at 16. Is this an antibiotic we could rely upon to treat a patient like this? And then what about other new options like imipenem relebactam? Well, to make a long story short, we've studied these isolates in great detail now, and basically have taken paired isolates at baseline and after patients have been treated with ceftoltezo. I'm showing you one example here where the number of isolates are listed chronologically, 1, 2, and 3. Days of ceftoltezo treatment, 26 and 45 here. I know we use ceftoltezo for 45, bad stewardship. Just remember, this is an LVAD patient, and there's not a lot we can do in these cases. And then you see new AMP-C mutations. And indeed, these AMP-C mutations were the driver of ceftolozane tazobactam resistance. But what I want you guys really to focus in on are these MICs. In parallel with the ceftoltezo MICs increasing, so too did ceftazidime and ceftaz-AV. In reverse, the imipenem MIC went from 16 to 2 to 1, and imipenem relebactam at the far right was fully susceptible. So we learned very quickly that AMP-C was the driver of ceftoltezo resistance, but that AMP-C resistance caused collateral sensitivity to other antibiotics. It also caused cross-resistance to ceftaz-AV. Here's all 23 patients put together. And the main bullet point is because of those AMP-C structural modifications, the enzyme essentially became very good at trapping ceftolozane. Remember that big R2 side chain I had circled in red? Well, essentially the enzyme opened up to accommodate that large side chain so it could hydrolyze ceftolozane. As a result of doing so, it changed the conformational structure of the enzymatic face. Imipenem, for example, which we saw increased susceptibility for, has a very important side chain known as a 6-hydroxyethyl side chain. That side chain can fully rotate away from that active site now and not be hydrolyzed by AMP-C anymore. Pretty cool stuff, right? But that's why we saw reverted susceptibility to imipenem. There's a structural biology reason for it, and we see it in our susceptibility results as well. So imipenem relebactam then may be a suitable treatment for patients that do indeed develop ceftoltazo resistance. There's now enzyme kinetic studies that show you what I just mentioned. Both ceftazidime and ceftolozane get hydrolyzed at higher frequency with these specific mutations in AMP-C, but also imipenem becomes much less hydrolyzed. Okay, so surely then imipenem relebactam would be more durable. Well, unfortunately, it's not the case because it's not the case for any drug with Pseudomonas. This bug always finds a way, I assure you. But I want to go back to a couple of things I mentioned before. This is a patient during 2021. We couldn't use ceftoltazo. Ceftaz-AV was already resistant, so we used imipenem relebactam for this 55-year-old newly diagnosed HIV patient. He had a recurrent infection. We gave him another 14 days of ImiRel. And not surprisingly to anybody, the organism eventually developed resistance to imipenem relebactam. But here's where the story gets really interesting. When we do the same kinds of series of studies where we use whole genome sequencing to look at serial isolates among patients, remember I told you before, we've tried for decades to figure out why imipenem's not effluxed out of the cell? Guess where we found mutations? In genes that encode efflux pumps, MEXB, MEXEF, OPRN, etc. And you can see that the imipenem relebactam MICs go up in the setting of the efflux mutations. But remember, imipenem relebactam is two different drugs, right? So is it that imipenem is being effluxed out, or is it perhaps relebactam? And so to answer that question, we used in the laboratory something we use as a very broad tool as an efflux inhibitor, a compound known as PA-beta-N. It basically knocks out all the efflux for all the pumps. And what we found by doing that is when we added PA-beta-N to ImiRel, we saw that MICs went down significantly even in the setting of these mutations. But when we added PA-beta-N to imipenem alone, the MICs really didn't change. And this told us then that true is true. Imipenem was not being effluxed out of the cell, but its bodyguard, its beta-lactamase inhibitor relebactam certainly was. And that's how Pseudomonas has overcome imipenem relebactam activity. Now, this patient was treated with cefiderocol, and I realize I'm running out of time, so I'll skip my cefiderocol spiel, other than to say this is a very interesting molecule that we still have a lot to learn about. You'll remember that this failed its clinical trial, the Credible CR study, where we showed higher mortality compared to best available therapy. And I'll ask the broad question as we wrap up, because of course we have a study investigating the effectiveness of MDR Pseudomonas for cefiderocol. I don't have an answer for you on whether this drug works for MDR Pseudomonas yet. But I will ask a related question of how durable is it in the setting of you've developed resistance to other stuff? Is this as a drug can you keep in your back pocket that might still be active? Based on in vitro data alone, the answer to that's probably yes. But it reminded me of this really interesting report from Will Miller in Houston, where basically they treated a woman with ceftoltazo for 14 days, and it had that same mechanism of resistance we just talked about. But somewhat surprisingly, they found, despite never being treated with cefiderocol, the organism also developed resistance to cefiderocol. Quite peculiar, right? The MIC went from 2 to 8, and they found new mutations in genes that encode iron transporters. Why would ceftolozane select for resistance in iron transport genes? I don't know the answer to that. I'm asking that hypothetically. But is it really possible? And the answer is yes. We found very similar things among patients. This is the patient that I showed you previously. When you add the cefiderocol MICs at the end here, look what happens. When you accumulate AMP-C mutations, you see a similar rise in cefiderocol MICs. Remember, it's a cephalosporin after all. And what I can tell you with some confidence is that some proportion of patients that develop ceftoltazo resistance will have cross-resistance to cefiderocol. And I think of this in the resistance world and studying mechanisms for a living as like the jackpot phenomenon. Because basically you got to hit 3 sevens in a row to get cefiderocol resistance. You have to have some combination of AMP-C mutations. You have to change its target binding site at PBP3. And then you have to have that third key component is mutations in TONB-dependent iron transport receptors, which is abbreviated here. So that's just a brief word on ceftobiprole, and I'll skip some of the summary points in case there are any questions. But we've come a long ways in the field of antibiotic resistance. We've seen a number of innovative discoveries. We've undeniably improved the lives of patients because of these new antibiotics. But at the same time, we have continued challenges. We're seeing the evolution of resistance to all of the new agents that we've talked about today. It will be a very short period of time before we see oral carbapenems used in our patients. And I think that will enforce a whole new level of precautions in our field. And then, of course, evolving resistance, there's many ways to overcome it if you understand the mechanism. Hopefully, I've shared some of those insights with you today. And even though we don't have randomized clinical trials, well-designed real-world studies help answer some of these questions as well. So I'll stop there, and thank you so much for your time and attention, both online and in person, and happy to answer any questions you have. Thank you. No one.
I think we have time for a couple questions.
Yeah, sure.
I'll start out. So, excellent talk.
Thank you.
I gotta say, a little impressed.
Sorry about that.
As long as there's funding agencies that keep supporting your work.
Also depressing. Yeah.
Yeah, but incredible, thought-provoking. Any thoughts or any experience in combining some of the new? I know double beta-lactams we probably shouldn't do, but when you look at emergence of resistance with cefaltazo and imurel and then ceftobiprole, any thoughts about combination therapy and whether we might be able to have more durability and less emergence of resistance?
Yeah, that's a great question. And so the question for those of you online is, might we be able to mix and match new drugs with new inhibitors to overcome some of this resistance, and what does that look like moving forward? We recently published a paper in AAC where we had the same idea in mind. Is we took ceftolozane, and we know because tazobactam doesn't offer anything, we said, well, what if you have ceftolozane relebactam, ceftolozane avibactam, beta-lactamase inhibitors that can actually inhibit AMP-C, which we know is the common driver of resistance. What we found is we could reduce ceftolozane MICs pretty significantly with those, but not all the way to basal levels, suggesting that AMP-C still hydrolyzes enough ceftolozane to cause some low-level resistance. So that could be true, but usually those interventions have to be employed before you have resistance mutations, what it appears at least for AMP-C. Now, imipenem relebactam, I think, is fascinating in that case because the mechanism causes increased susceptibility to imipenem. So it's a good countermeasure, again, if you kind of think about the mechanisms. I think the real challenge to this question is going to be sulbactam, durlobactam. Those of us in the pharmacy know that sulbactam and durlobactam are packaged separately. And you could, in theory, use durlobactam with whatever else you wanted as a beta-lactamase inhibitor. And we think of this, even though I didn't talk about Acinetobacter today, as an Acinetobacter-specific drug. But the reality is durlobactam is the best version of diazo-bicyclo beta-lactamase inhibitors that we have. And it very well inhibits many of the enzymes we talked about, with the exception of metallos. So I do think we will see some people getting creative with that combination. Perhaps we will get creative with that combination in Pittsburgh. But I think it's going to happen. And I think the other thing that's going to happen, Dr. K, is these drugs are now getting to a point where they're going to start rolling off patent in a year or two, which again seems remarkable, but it will open up those doors to be more creative because it won't be co-formulated.
I think I know the answer.
Yeah. It turns out when you're the first to the party, you're also the most popular. And I think that's really the reason why. Now, there's a few things. Oh, yeah, I'm sorry for that. The question in the room here is, why is ceftaz-AV used more commonly than meropenem vaporbactam? And my response is it was approved first. And I think the context of it being approved first is really, really important because we were so desperate to not use colistin or aminoglycosides at the time this drug was approved that it was almost a no-brainer. Even though clinical adoption was actually slower than many of us thought it would be, it was a no-brainer to go to an active beta-lactam. Compare then when meropenem vaborbactam was approved, well, you already had an active beta-lactam on the market. And of course, the difference between two in vitro active beta-lactams is relatively nuanced. We're talking about better PK, but both are going to test susceptible. The clinical outcomes data didn't suggest there would be any difference. So I think these are things we're learning over time, but I think it was all about timing with ceftaz-AV and that we were desperate. Yeah. 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 Yeah, and so the question here is, was ceftaz-AV being broader, perhaps is that a reason why it was used more commonly? And certainly in the case of Pseudomonas, which is far more prevalent than KPC in the United States, could have driven a lot of the ceftaz-AV use as well, right? Because ceftoltezo came around at the same time. So people were certainly using ceftaz-AV for Pseudomonas in addition to CRE, and that could be another reason why it was preferentially used. I'll say from the pharmacy side, there was a lot of questions about whether you should have both of them on the formulary. Dr. K wrote a nice editorial about this, but do you need them both on formulary or do you just need ceftaz-AV because it is broader? And I think we're starting to get some better insights into those questions over time, but when people were making these decisions, none of this data existed. I hope so. Yeah.
You guys, thank you. Thank you so much.
Yeah, thank you very much. I hope whoever's recording is able to stop. Oh, okay.